Hello and welcome to the Shreveport Fire Medical Director Minute. This is hopefully one of many in the future. Today I'm just going to go over the information that I gathered whenever I went to Gathering of the Eagles. For those of you not previously exposed, this is a presentation put on yearly by Dr. Paul Pepe, one of the fathers of EMS, and he, along with other medical directors across the country, who are tested and experienced, put this on through UT Southwestern. And these are some of the highlights that I just want to share with the Shreveport Fire Department. So our first presentation is about diversion and how we're dealing with diversion. So it was a really great example of innovative thinking and how innovative thinking can allow us as EMS providers for new ways to deal with problems in our system. So, for instance, this is from the New York Fire Department's medical director, and he took a progressive approach to the diversion issue. And so what they did, instead of waiting for hospitals to decide it's time to go on diversion, they chose to proactively seek out hospitals that may need to go on diversion. So if a unit or several units were on scene at the hospital waiting for a bed more than 30 minutes, they immediately sent out a team, a supervisor generally, in order to go investigate. So 3 units out of service, more than 30 minutes, a supervisor goes to the hospital, investigates what's going wrong there, and then decides, does this hospital need to go on diversion? Is there a new acute nurse that's causing the paramedics to stay too long? Is it that they're having too many people come in from the waiting room? Have they just had a mass casualty event that they're still trying to deal with? And so this is a really progressive thing in that they're not waiting for the hospitals to tell them when it's time to do what. They're saying that these are our patients and we have to take the best care of them. And in order to do that, we're going to tell our own providers what we need to do with our patients. And if that's go to hospital A or go to hospital B or tell them no longer go to hospital C, that's what they're doing. So once they find the issue, if it's needed, then the EMS supervisor will actually put the hospital on diversion. So the hospital is placed on diversion by EMS. As great as this policy may or may not be, I think the interesting thing and the wonderful thing here is the innovative practice that they're taking. They're saying that these are our patients, we need to take best care of them, and we need to decide where they need to go and when, and what's going to be the best thing for them. Because until they get to the hospital, they're all ours, and it's our responsibility. And I really love that, and I think it's a great future for EMS research and policy. So the next presentation that we're going to go over is one of many on strokes. Dr. Ann Tevy, who did this presentation on invasive interventions for triage for stroke, he had a really interesting story that really captivated us because he talked about his grandfather's history with stroke and how his grandfather's interventions really saved his life. I know I always say that whenever we're dealing with strokes, we have people's brains in our hands. And so one of the things that they're doing is much more invasive, much more aggressive therapy for strokes. And one of the ways that they're doing that is now not only can we give systemic TPA, not only can we go in and actually do catheter-directed TPA, they can also go in and grab the clot. So all 3 of those treatments are available. And so what he presented that day was how is it that they're identifying these strokes in the field, and then what are their outcomes with these new innovative therapies. In 2015, the American Heart Association and the American Stroke Association approved many more therapies than were previously allowed. And they're having great success with these, and that's what he was going over. I want to just make sure that you're aware that stroke right now is a large area of research, and it's going to continue to be a large area of research, both in the pre-hospital setting and in the hospital setting. In pre-hospital settings, there are places that actually have mobile stroke units where they send out a physician, a neurologist, and a nurse with a CT scanner loaded, and patients who would not otherwise be eligible for the stroke therapy with IV TPA are getting it on scene. Amazing strides that are being made. I think that one of the things I really want to make sure that you remember is that as EMS providers, you can get 3 of the 4 required things in order to identify a stroke. You can find someone who has symptoms of a stroke using the Cincinnati stroke scale that we use. You can get the blood glucose, which helps rule out one of the most common stroke mimics, and then you can get the oxygen saturation, which helps us identify, is this actually hypoxia leading to stroke-like symptoms? And the earlier you're able to notify a hospital, the earlier that hospital can mobilize the resources in order to ensure that any patient who would be within the window for life-saving, life-protecting therapies would be able to identify and get those therapies. The next presentation was by Dr. Gallagher from Phoenix. On his presentation, he really focused on medical errors in EMS. He looked at all the data that he had from his system. He looked at what errors were happening and tried to find solutions. And the important slide that I'm going to highlight is what were his top 5 suggestions to improve and stop making so many medical errors. So the first of these 5 is always double check the drug and the dose. Don't second guess yourself, but always double check. You confirm that you want your password to be saved in your computer, and if you're confirming that you want your password saved in the computer, we should at least use that same amount of caution whenever we're giving drugs to patients. This is to protect the patient, but also to protect you. Make sure that you are always in the right mindset whenever you're giving these medications. The second one had to do with narcotics, putting them in a separate container, tamper-resistant bags. This is helpful because this protects the patient from getting medication they don't need. This also protects you from any suspicion of any inappropriate use. The third is don't be in a hurry to give the wrong medication. We have a lot of things that we have to do very quickly, but giving the wrong medication isn't one of them. Take the time, slow down, check the drug, check the dose, check the location that you're going to give it. Make sure that you're putting all these checks and balances. What you don't want to do is give the wrong dose to the wrong patient. So get the right medication and the right dosage to the right patient every time. For kids is always a source of angst in EMS and actually even in the hospital. We're always worried about hurting kids. We don't want to do the wrong thing, and we always want to make sure that we're double checking those medications too. As long as you're going by the Broselow tape, you're going to do it right. They even have these idiot-proof syringes that will help you with that, but you don't need that. What you need is to take the time in order to measure out the child according to the Broselow. Draw up the medication, confirm that you have the same amount of medication in there that's measured on the Broselow tape, and then deliver the medication as appropriate. The fifth and final tip from this guy is actually the one that's most important to me, and that's that we all need to know that mistakes happen. We're human. Mistakes are going to happen. Mistakes in EMS are just like mistakes in the hospital. And one of my great mentors told me the very first day as I was a third-year medical student, he said, mistakes are entirely expected and entirely unacceptable. You're going to make a mistake, but what we have to do is try and minimize those. And whenever we identify them, we have to report them. Reporting them protects you, and it protects me, and it protects our whole system. The most important reason that we report them, though, is not even for protection's sake. You are a smart provider. You made a mistake, and if you made a mistake, then there may be something wrong with the process that caused that mistake. By identifying them, you help us as a group to go in, look at why that mistake was made, and maybe fix a process in order to prevent that same mistake being made by another provider. By bringing any mistake to the light, you can help identify solutions in order to prevent this in the future. The next presentation was on freestanding EDs, the next one I'm going to go over. Dr. Tylek did a presentation on this, and while this does not yet directly affect us, I think that this area is ripe for the picking for a freestanding emergency department. We have very busy urgent cares, we have very busy hospitals, and I wouldn't be surprised to see one pop up in the future. So what we need to understand is what are they, what can they do, and what can they not do. So ACEP put out a guideline for freestanding emergency departments and what they're required to do. They're required to treat any patient or at least evaluate any patient who rolls through their doors, whether it's walk-in or from an ambulance. They also put out a guideline for what would not be most appropriate for the freestanding EDs. Any patient who needs immediate intervention, such as a STEMI, such as a stroke, such as a multi-trauma, may not be best served by a freestanding emergency department. They probably need a fully integrative hospital. However, any other patient who doesn't need immediate service or it's unclear as to whether or not they need immediate service might be a great individual to be served by a freestanding emergency department. Again, this is not an issue for us yet, but it's an interesting thing to think about, an interesting thing to be aware of. The next piece by Dr. Richmond had to do with reviewing data also. He was looking at what was working in the system and what wasn't working in the system. In order to do this type of research, you have to have good data, because data in equals data out. And if the data we're putting into our systems, if the recordings on our patient charts suck, then our information out is going to suck as well. So be aware of this anytime you're doing any of your charting. Recognize that if I'm going to measure and evaluate, I need good data in order to get good information out. One particular thing he noted was that as he was looking at his data from his resuscitations, CPR resuscitations, he saw that there were long pauses in the resuscitations, and he identified that a lot of the times that was as they were putting the Lucas on, they were pausing for more than 15 seconds. A 15-second stop in chest compressions decreased what they call the chest compression fraction, the amount of time that they're actually physically doing compressions on the chest. Anytime you decrease that, you decrease the survivability. So what he did was he actually did an intervention, he did some teaching, and he encouraged his crews to decrease the time that it took them to place the Lucas device on the patient. By doing that, he actually increased the survivability. He reevaluated the data and had a positive outcome. Every second that you're not on the chest for CPR, that decreases the survivability, and by improving our chest compression fractions, we can decrease our mortality rate. Dr. Corey Slovis from Vanderbilt did the next presentation that I'm going to talk about, and I drew really 2 to 3 points from this talk. So the first one that I reviewed was the modified Valsalva. Valsalva treatment, obviously, as we all know, Valsalva maneuvers are the first-line treatment for SVT. And so generally, they're only 15% success rate. And by doing the modified Valsalva, which really just includes having them Valsalva for 15 seconds, lay them flat on their back, and raise their legs for 15 seconds, full 15 seconds, then return them to sitting position. By doing those small interventions, they were able to increase their rate of success from 15 to 45%. That's huge, 3 times more effective. That's a huge amount of improvement. And it's much safer than chemical cardioversion. I did try this so far. So far, I haven't been successful, but that same patient was also not successful with chemical cardioversion. So I'm not giving up on this, and I think this might be a great new technique that we use in order to help break SVT. The second of the 2 articles had to do with survival statistics in ALS versus BLS. So what they found was that in trauma, stroke, respiratory failure, patients who were transported by a BLS ambulance versus an ALS ambulance actually did better. They had more survival, and it's anywhere between 7 to 4% better. They found that with acute MIs, they were doing better with the ALS. Survival was better when they did the ALS ambulances. This is a really hot topic in emergency medicine literature right now. It's a very hot topic in EMS literature and research, and very controversial as well. No one wants anybody to take away their toys. Whenever I look at this information, what I really draw from it is that people are having trouble remembering the fundamentals. Whenever you're on a sports team, you go to practice, the very first thing that you practice is the basics, the fundamentals, the footsteps. What are the small things that I do in order to get myself to be a great champion? And so in order for us to be champions in the EMS world, we have to focus on the fundamentals. In association with that last slide, this slide also talks about survival, but it talks about neurological outcomes along with survival. And neurological outcomes were better with BLS over ALS for all the disease entities just mentioned. I really want to say that I think this is a focus problem. This isn't a delivery problem, but paramedics have all these tools that they want to use. And so they're so focused using these tools that they have this opportunity to use that they forget to go back to the basics. Always focus on your fundamentals. EMS Compass. I present this with excitement and some trepidation. This is from NASEMSO. It's an initiative in order to help us be able to assess quality better, to be able to compare one group versus another, and to do quality improvement, and actually to do billing as well better. They've sat down, they've looked at what is it that they can evaluate that will help them understand how good a system is doing. They're comparing ALS, BLS, and they have an interesting approach. And response times, so not very surprisingly, are not even involved in what they're measuring right now. This is all about treatment. Currently, they're looking at what it is that they need to measure. They're going to focus on the clinical process. Are we getting a glucose for stroke? Are we sending our STEMI EKGs to the hospital? Are we giving an aspirin in chest pain? They're looking at all of the types of interventions that are considered basic, and they're using these as metrics for measurement of and comparison. These metrics hopefully one day will be available to the public, and they'll also be tied to reimbursement. So these are things that are coming down the pipeline, and we need to be aware and keep our ears and eyes open for what's happening in the future of EMS. The next presentation is from Dr. Brent Myers. He is the president-elect of the National Association of EMS Physicians. Dr. Myers did a review of what happened this year at the most recent meeting. So his top 5 included active assailant, reform, narcotics epidemic, advocacy, and international outreach. As far as active assailant goes, we know that it's coming, and we at Shreveport Fire are making headway in order to make this happen. You are going out and getting active shooter training, and hopefully those will continue and that those are going well. Please give us feedback as needed. As far as reform is for real, this has to do with the last presentation. The EMS compass is out there, and then it's coming our way. Narcotics epidemics with overdoses have now significantly increased over past years. And currently, they are up there with motor vehicle crashes as one of the leading causes of death. Especially now that drugs are now being laced with fentanyl, those types of overdoses are happening more and more frequently, and they've actually had epidemics in certain little areas where multiple people have overdosed in a matter of hours. This is hopefully going to change with some of the changes that are happening in the hospital setting as far as CDC's recommendation for opioid prescription, but we'll have to see where these go. Advocacy changes, reform is for real is what he said, and he's not lying. There is a bill out there, HR 4365, and this bill talks about how are we distributing, how are we moving our narcotics within each of the EMS systems. This is so that we can make sure that we're still able to give narcotic medication to our patients. So if you haven't already, make sure that you read this bill, you understand this bill, and then contact your congressman in order to try and help him decide that it's time to support it. Dr. Brent Myers and others with NAMSP have gone across the world in order to put on medical director courses. EMS groups across the world are working together to improve practices in patient care. EMS at the apocalypse. This was a fun and interesting topic. An EMS physician from New Zealand was asked to plan for businesses for a true blackout event, for an event that's lasting not just a few hours, not just a few days, but weeks, months, or more. And it's really interesting some of the things that he commented about. While I pray this is an unfathomable, unrealistic thing, some of the most interesting points I took away from it was that most people, most programs, most entities only plan for a 72-hour sustainability. They only plan to be operational for 72 hours without a resupply. That's not necessarily realistic if you have a true blackout event. And so he's actually planning for a business to go ahead and be able to do it longer. So as EMS, as some of the emergency responders, what are we thinking as far as being operational for more than 72 hours, for being operational a week without having resupply? I thought it was an interesting thought. The other thing that I thought was interesting for sustainability of any program, one of the things that he said you had to focus on, and I agree, is that the sustainability of your employees' families. In order to ensure that those employees are going to come in and serve during these difficult times, you have to ensure that those employees have safety and sustainability for their own families. I loved that, and I would love to see that to be taken into consideration in the future for us. The next slide I actually use differently than what it was intended. The top 10 safety concerns of EMS crews and agencies actually referred to things like ambulance crashes, on-the-job injuries, and I used it to remind myself to talk about something else that I know is big in the literature for EMS right now, and that is mental health of our providers. We have a hard job. You have a hard job, and you see things that would make other people sick to think of. Being out on the streets is much different from what I even see in the hospital, and it is very difficult, and it takes a toll on your mind and body. There's been an increase in the rate of suicide of EMS providers, and provider safety and mental health has become a large area of research and focus, and I think that is absolutely needed. We can't take care of our community if we aren't taking care of ourselves. This is an area that I really would love to see us move more on. I would love to see us do more activities with debriefings, more activities with ensuring provider safety, not only of physical but also mental health. There's a ton of support initiatives out there. There's something called the Code Green campaign, Safe Now, and Share the Load, and these are great resources out there. This is an important issue to me, and if you have an interest in this, please contact me, and maybe we can work together in order to do something better than what we've done in the past. The next couple of slides are just a few quotations that I pulled out of select presentations, but I think that they speak volumes standing alone. The first one is by Rabbi Berg. If you look him up, there's some questionable activities on Wiki if you find them, but I think this quote is an excellent quote. Personal responsibility is not only recognizing the error of our ways, personal responsibility lies in our willingness and ability to correct those errors individually and collectively. I think this quote is fantastic. I think we have to remember that we are the sum of all of our actions. We as a collective are the sum of all of our actions. The only way to get better is to identify issues and address them head on. Feedback, feedback, feedback. I hope that in the future I'll be able to give you better feedback individually and collectively. I want to be able to help give you what you need in order to serve our community. The next quote is by Grace Hopper, and she was known as Amazing Grace. She made the modern day computer possible by being innovative. In addition to this quote, she said her best accomplishment was being an educator. Every day is a new day, and we have to look at things in a new way every day and ask, how can I do it better? Her quote is, the most dangerous phrase in the language is, we've always done it that way. So every day is a new day and an opportunity to improve. This last quote is, we are all DC. This was in a presentation that I highlighted earlier, but I did want to say we had the opportunity to hear from Dr. Saucy. She was eloquent, poised, and focused on her role as medical director. She mentioned some things that prevented her from fulfilling her role appropriately, but in the end, just as the slide says, I think we all know that if we aren't vigilant about doing what we do well and doing it the best that we can and learning how to improve from previous times, we could all be DC. So as I look to the horizon, I see many great things for this organization. I would love for us to have a focus on the fundamentals, for us to function as a collective to improve each day, for us to recognize our weaknesses and strengths, both individual and collective, and to do our part to improve. I would love for us to continue to learn and develop, to watch as the research improves, and then one day become involved in the research ourselves. And as I come to a close of my first presentation, I want you to know that no matter where I'm going, as in the first picture, if I'm driving back to Shreveport on the road in Mississippi, if I'm in Rome or other locations abroad, each of you is in my heart and mind. If there's ever anything I can do for you or for this organization, don't hesitate to ask. This is my email. Please use it. Tell me what you want me to focus on for the next Medical Director Minute. Tell me about an awesome case that you had. Tell me about an awful case that you had. Tell me about the challenges that you face day in day. I look forward to your feedback and many questions. Thank you.